morning, everyone. Thank you very much, Ian. He gave us a rather terrifying overview.
I thought it was a positive one.
Not of me, of the market access. Perhaps that was terrifying too. I'm definitely no expert on the payer side of the business, but I guess what I do have going for me is that I've been around the block a few times, which I guess over the years has given me some insight into how some of these things affect the way we do business. So to start right off, we're going to start with a question. If you were around 20, 25 years ago, think back and think about what were the important criteria that you or your company looked at when you were trying to make a decision whether you're going to launch a drug. Let's see. Yeah, I would agree. Number 2, that was pretty much how we did it. Oops. When we look at when you look at this cartoon strip, I think this is how I remember it. You got a drug, you launched it, you had keen reps, receptive physicians. If you had some side effects, you came up with another drug. Basically, you had to get the drug approved to get on the market. And once you did that, your reimbursement was pretty much guaranteed. But what's happening now? We used to look at the cost of entry. I remember as a market research analyst sitting there going through loads and loads of data on the cost of entry. If Glaxo was there before us, it was a matter of how much more to spend. What were we going to do to get to market? And now things have changed significantly. If we take a look at 90,000 feet and we look at how we maybe do things today, we study it for sure, we price it, we figure out how to manufacture it, then we go back and figure out how to manufacture it better and cheaper and for less. Then we take another look at price. We look at the rest of the world, the US, and then we might even delay our launch because the US hasn't launched, and we need them in the price mix. So I guess my point is that things have gotten quite complicated, and the areas where we used to spend our emphasis, physicians, education, training reps, having reps talk to physicians, it's changed. Companies that used to compete in the market, you'd almost never talk to them, now get together to form alliances. You get companies getting together so that they can collectively get the products on formularies so that their patients can access them. So where do we get these ideas from? Well, the numbers speak for themselves when it comes to reimbursement, and I'm not going to spend a lot of time on the numbers, but if you take a quick look, you can see in the last few years the do not list rates for submissions going through the CDR. And again, not that I want to reminisce too much, but back in the day, if you were a marketer, to be first to market, first in class, that was the holy grail. That's all anybody ever wanted. You set the price, you set the bar, and you took the market share. If you take a look at that, that's like a death knell. First for disease, first in class, the likelihood of you getting a listing is slim to none. And then, if you look at the other side, if you look at the reasons, if there was clinical reasons why you didn't get the listing, a lot of them are related to comparators, insufficient evidence. They don't like the outcome measure that you used. How does this happen? We just got the product approved by Health Canada. It was approved, it's safe, it's effective. That doesn't translate over into reimbursement. So things have changed. We spend a lot more time on clinical data, generating pharmacoeconomic data. And what's that leading us to? Who's in the driver's seat? Now, Mitch, I think he stole this slide from me, actually. So that's good. I don't need to spend a lot of time on it. But you can see from who is making the decisions, who is deciding how products get, who makes the choice, on which product you're getting. If you look, the healthcare professionals, their influence on choosing products is declining significantly. The influence of the payers, on the other hand, is going up significantly. And as we've already talked about a couple times today, the importance of patients is becoming much more clear. Good. So what does that mean, though, for us? Who do we cater to these days? So the next question is who do you think about? Do you think about the physician? Do you think about our own needs, the fact that we need to make money? Or do you think about some of these other regulatory bodies? Let's see how people do it these days. All of the above. I guess that just serves to demonstrate again that things are getting complex. We're spreading ourselves thin. We have a lot of different stakeholders that to look at. So I have spent actually, in the last several years, most of my time has been spent actually in the dermatology area. And so I wanted to take a look at how they're doing it. And I think some of the comments that George made on the dental side are quite relevant to dermatology. When it comes to reimbursement, they're pretty much not doing it. And that's kind of key to their, I would suggest, some success that they're having these days and how they're managing to drive their business forward. If you look at the number of submissions in the last 7 years that went to CDR for dermatologic products, there was only 10. 5 of them were biologics. 4 of those actually were listed with criteria. The other 5 non-biologics, only 2 were listed and 1 with criteria. So with all the products that were definitely approved, very few of them go to CDR. So they're not doing it. And why aren't they doing it? Well, it's always been inherently difficult, but what this demonstrates is that they don't bother. There's other ways to do business. And this also shows, though, how important some of those stakeholder groups are. Those biologics are quite costly, and this is definitely a demonstration of the significance of things like the Patient Alliance that got together the stakeholders, the physicians, the patients, and the companies to ensure that patients have access to the drug. So how is that relevant? What do they do? If they're not doing the traditional things, what are they doing? Well, you know, we have a lot of our derm colleagues in the audience, but you'll notice that very few derm companies are only prescription products. They've got medical devices, they do procedures, they do injections, medical cosmetics. Why are they doing this? Pretty much for the same reasons that you know, they do in the dental industry. Why? They already have deep relationships with the patients and the patients and the physicians. And there's money to be made. There's good profit in it for both parties. And why is that? Even if at the very simplest level, you're not looking at PMPRB pricing. You're not looking at having to spend money on reimbursement. So you can price in a free market, which is always good. And when you have such a deep relationship with your physician, in these cases, you're selling directly to the physician. So like the dentist, your relationship, you have one product, you add another, your physician becomes a customer for life. The margins are good and your spend is predictable. That's why they're doing it, and I think it's being successful. They're not the only ones. We're moving more away from a vertical integration to perhaps horizontal. We see it in derms, we've seen it in the dentist, and you see it in areas like cardiovascular. You know, cardiologists went from prescribing beta blockers and ACE inhibitors to doing procedures, surgical procedures, to you know, obesity treatments, weight loss clinics. So more and more you see the specialties are wrapping things into sort of an all-encompassing experience for the patient. And why? Because patients want it and they need it. And quite frankly, it's good for both industry, our physician friends, and the patients. So we talked about our industry then and our industry now. I don't know how many of you have ever felt like this. You finally get your big approval, and yet you feel like someone's thrown a wet blanket over you because your trials have only just started. So it's not all bad. Some of it's good. We're getting smaller as an industry. We probably have fewer sales reps, but they're being used more efficiently. And overall, I guess this has developed another whole industry in itself, and that's sort of government relations. A lot of those departments, I think, are as big as marketing now. So last question, we're just about done. I just want to see if you've actually changed your mind about how you choose to launch a drug and the criteria that you may find important. 51%. Well, I would agree. And again, it just serves to show us where we're going and the things that we have to consider. Now, my very last slide, and that's the end. I don't think we've diversified quite to this extent. I don't think Valiant's bought an oil rig or anything yet. But I think what that does is you know, we kind of snicker under our breath, but there is some reality in that. And I think regardless of the stakeholder, physician, patient, payer, we have to realize that we're in business and we're in it to make money and generate shareholder value. Thanks very much.